Hey everyone, this is Tim, your lecture instructor for the Paramedic to RN Transition Program. And this is going to be a pretty short, fast, quick PowerPoint and lecture on PreOp, OR, and PACU. This is following your book, the 14th edition, chapters 17, 18, and 19. And so basically, with PreOp and PACU, it's more about assessment and data collection. And the OR, it's actually more of the intervention itself. So what I'll do is I'll follow along with your book and I'll point out some boxes that I think are important for you guys to know and need to know. And we'll go from there. All right, so we have surgical classification. Surgery can either be diagnostic, which means they go in and they're actually looking around and looking for something. It can also be a cure, whether they're removing your appendix or actually going in and removing either benign tumors or removing a problem that's causing your illness. They can also do repair, such wounds as, they can have decubitus ulcers, they can have wounds on their legs and butts, bony promises, things that they really can kind of clean out, sew up, and help heal on its own. They can do reconstructive, which is more like breast or tummy tucks, and I think it's probably more elective. But I've also had patients who have been either bitten or cut, or I've had a guy that got hit in the head with a 2x4 in a bar fight, and the doctor had to come in and actually reset his nose and actually stitch his face back together. So they also have palliative, which is, again, these are people who are actively dying, but they can still do some interventions in order to prolong their life a little bit. And then they also have rehabilitative, which is knees and hips and joints. So categories of surgeries, we have emergent, which is now, working at Osborne. It's a trauma center, so I've actually had patients that have come in with horrible car accidents and having to come in and go straight from the emergency room to OR to have either, legs and arms and things fixed. They have an urgent, which is within 24 to 30 hours. That could be either appendicitis or it could be your gallbladder removed. Things that need to be done, but in the same sense too, they can kind of wait and hold off until they have to. They have required surgeries, which is in a few weeks or months. They have elective, which is something that they should have done, but it's not necessarily life-threatening. And they have optional, which is more personal preference. So preoperative. With preoperative, it's actually having surgery before, or I'm sorry, it's actually the step above before surgery. So basically, your patient will be called down to pre-op, and that's where they actually collect all the information and getting them ready for the OR. And the OR is actually during. And then PACU is actually after surgery. You'll go there, you'll actually recover from anesthetic, and like I said, they'll just kind of get you all back to where you were before and send you on your way. So with pre-op, it's pre-admission testing, which is also called PATS. It's admission data and patient demographics. They'll collect a health history, and they'll also make sure that all the consent forms are actually signed. And if they're not, they'll actually do that then. And then they'll also do a surgical safety checklist. Now, this says page 423. That's from the old book, but it's now the page 420 in chapter 17. And let's see here. Examples of nursing activities in the preoperative phase of care. So this is actually pretty interesting in the sense that, again, you're really collecting a lot of information, collecting a lot of data. You really want to make sure that nothing's going to go wrong during surgery. So they'll ask you a lot about, the medications you're taking. They'll make sure that, that you've had some sort of prior testing too. And like I said, just really making sure that all the consent forms are signed. And I also put in here, highlighted in red, that your patient needs to be NPO. There's a lot of controversy or a lot of research that's been done to determine whether the patient has to truly be NPO for 8 hours, or if they need to be NPO for 6, or do they need to be NPO for 4. Essentially what they're doing is you're making your patient NPO because during surgery a lot of things can make your patient sick, and they don't need to be throwing up in the middle of it, and then of course they can't really protect their airway or actually get it up and out, so it goes straight into their lungs. So this is really just making sure that they don't get sick during surgery, and that if they do, it's not actual food. So where I work, NPO is usually 8 hours, and then based on what they've actually had, sometimes anesthesiologists who are probably the ones who truly determine whether or not they'll do surgery or allow your patient to have surgery. Some of them actually believe that they can either do it 4 to 6 hours prior or after they've been NPO. And again, it's also based on what they've had. If they've had a lot of protein, that takes too long to digest, so they tend to wait. Whereas if it's either clear liquids or things that are easily digested and disposed of, then they tend to kind of do surgery a little bit sooner. You have to make sure you have a surgical consent. This should be in writing. It should contain the following, which is explanation of the procedure and the risks. So if you have a patient who is having a appendix removal, the actual consent form will say laparoscopic appendectomy. And then when you flip over the consent form, it actually will tell you, here's all the things that could potentially happen while you're having surgery. The descriptions of the benefits, there's alternatives to it. So if you're doing the appendectomy, then sometimes they'll say, well, we can kind of hold off and wait the 24 hours for things to calm down. I actually had a patient who came in with a ruptured appendix, and because she was so young and because of I was really kind of curious why they didn't actually do surgery to repair it, but they said based on where it was and the rupture, the body actually fixed itself, and she was there for about 5 days and didn't need surgery at all. So sometimes, you would think that they would have surgery for one thing, but a lot of times they'll actually kind of wait it out, and sometimes it repairs itself. I've had a patient who had a gallbladder attack, and they came in, and doctor said, let's give him 24 hours of rest and clear liquids and see how he does. And within 24 hours, the attack kind of went away, and that doesn't mean they won't ever have another attack, but he didn't necessarily need surgery at that time. So there is alternatives to what we think that, we should roll them down, cut them open, cut things out, and sew them back up and send them on their way. Sometimes if you give it time and some pain management and some clear liquids, a lot of times things will, kind of resolve itself. Offer to answer questions about the procedure. There's nothing wrong with the doctor going in, explain the procedure, letting the patient know what they're going to do, and then of course he leaves, and then next thing you know, the patient has a million questions, and you're standing there going, I don't know. Your experience with surgical patients, you'll start to kind of get to know what procedures they're having done and how it works and what they're going to do and how to feel before and after and all their stuff. So there's nothing wrong with actually explaining again what is being done, and as long as your doctor did it first, then you pretty much can reiterate and educate your patients on their procedure. Instructions that the patient may withdraw consent. Every patient has the ability to consent to having a surgery, but people get scared, people get cold feet, and at the last minute they decide they don't want to do it, and that's okay. That's their right. Statement informing patient if protocol differs from customary procedure. So, you can have, let's say, a laparoscopic appendectomy. That's basically them removing your appendix, but laparoscopically, which is basically 3 prongs with 3 puncture sites, and they go in, and they actually cut it all up, and they suck it all out. If it's too inflamed or if there's actually complications, then they will actually do a surgical incision midline and open the patient up. So the protocol differing is that it's going to be a laparoscopic appendectomy versus a open. So that way the patient understands that when they wake up, all of a sudden they've got this 6-inch incision from their sternum to their belly button, and not knowing why they just don't have the 3 puncture sites, and that's because sometimes there's complications. Let's see here. Other surgical consents. Valid consent must be freely given without coercion. So basically, you go in, the doctor explains it, you reiterate things, you explain things to them, answer all their questions. But in the same sense too, this is their choice. Either they have it or they don't. And regardless of what you believe or how you feel, pretty much it's irrelevant. So you can't really say, well, you need to have the surgery, or and it's, like I said, it's completely up to them. And I said this in the past, it's okay for your patients to ask you for your opinion, as long as your opinion is, unbiased, and you explain to them that this is, my opinion, and this is what I would do. And because I've had patients all the time ask, well, what would you do? Or what do you think? Or do you like this doctor? And, and like I said, you just kind of, they want validation from you because of the fact that they're scared and they don't know. And like I said, the more questions they ask, the more, they just want to make themselves feel better. And like I said, it's okay to actually give you some sort of unbiased opinion. Patients must be at least 18 years old of age. That's because of the fact that if they're not, they need a consent form from their parent. Consent must be obtained by the physician. So basically, the physician goes in, explains the procedures. I will tell you that 9 times out of 10, the doctor does not get the consent form signed. But as long as the patient does agree to having the procedure, then they'll tell you to get the consent, and then you just fill out the paperwork. Patient's signature must be witnessed by a professional staff member, which is you. So basically, the patient will sign the consent, and then you'll actually sign that they actually signed it. So for pre-op, they have diagnostics, which is going to be a cardiac clearance and a chest x-ray. The cardiac clearance is going to be, an echocardiogram. They're going to do an EKG. They will also do some lab tests, which is CBC, H&H, coagulation studies, electrolytes, UA or urinalysis, and a type and cross. So for the cardiac clearance, the EKG and the echo is really truly to see if your heart can withstand having surgery. And also the EKG is done to make sure that, if you're sinus rhythm before, then during you should be sinus rhythm, and after you should also be sinus rhythm. So the idea is really just kind of make sure that there's no changes with that. The chest x-ray is to make sure that you don't have any type of, either infection or that your lungs can actually perfuse well enough, because during surgery, these patients are being sedated, and they're a lot of times having machines breathe for them. Anesthesiologists can at least make a determination as far as medications or the ventilator itself, and determine or make sure that you're able to breathe okay. For lab tests, the CBC and the H&H is really to make sure that you have enough packed red blood cells, that if you do actually bleed in surgery, that you have enough, or whether or not you actually need more of them. And that's the reason for the type and cross. Most surgical consents, most surgical procedures will have a consent for the procedure, but then they'll also have a separate consent for a type and cross. And that's just to be, like I said, just make sure that if there's, for whatever reason, a complication, then they have blood available so they can actually give it to you. Coagulation studies, again, they want to make sure that your platelets are high enough, so when you do have surgery, you're not going to bleed to death, and that once you're done with surgery, that you actually recover, and the scabs and the clotting and everything else will be fine. So. Also with pre-op, the pre-op assessment, prescribed over-the-counter medication. This is to make sure that, like I said, during surgery, that your anesthesiologist will know what medications that you're on and any possible indication, counter interactions with other meds. Nutritional and fluid status. They want to make sure that if you have enough, protein, or you want to make sure that you're healthy enough to be able to have surgery and then afterwards actually be able to heal. The fluid status is, again, you don't want your patients to be fluid volume deficit. Especially during surgery, they'll do ventilators and stuff, and that actually loses a lot of fluid based on machine breathing and actually dries you out. So they want to make sure that you're hydrated enough. They also want to know about drug and alcohol abuse. They want to make sure that you're not going to go through some sort of, reaction to the anesthetic based on the fact that you're an alcohol or drug abuser. I've actually had patients that I had a patient who smoked meth the day before surgery, and he was a meth addict, and he actually had surgery, and he came out of surgery and went to PACU, and as he was recovering from the anesthetic, he got very violent and very angry and very delusional, and basically they had to sedate him again and ship him off to ICU. I'm a firm believer that the the emotional status of your patient prior to surgery is the way they actually come out of surgery. So if your patient is very nice and calm and relaxed, then most likely they usually are very calm and relaxed when they're trying to recover from the surgery in PACU. If your patients are very anxious and very upset, they tend to be that way when they come out. And again, I've had patients that have gotten very delusional and not know where they are. And there's a difference between being confused based on anesthetic as opposed to being delusional and having a reaction from the anesthetic and not knowing where you are and just being deranged. You also make sure that there's a good respiratory status because, again, they're going to be sedated and put on some sort of ventilation. Cardiovascular status, make sure the heart actually works well. Hepatic and renal function. Again, your kidneys and your liver have to be able to process the anesthetic and all the things that are happening at that time. And again, psychosocial, cultural, and spiritual beliefs. I have it here in red, providing education about what to expect before the procedure and after. So it's a really good idea to be able to not only explain to your patient what procedure they're having done, but what to expect. Your patient's going to have an appendectomy, and this is what they're going to do, and here's what the incision may look like, and here's what the 3 puncture sites may look like. They're going to put a IV in you. They're going to put you in a pre-op. They're going to ask you a lot of questions. They may give you a little bit of sedation, maybe give you some anti-nausea medication. Then they're going to kind of give you something to kind of make you a little sleepy, a little drowsy. And they'll take you to the OR, and you're not going to remember anything. And then you'll wake up in another room, and here's all the things that you should be feeling and all the things that they'll be doing to you. And then when you come back to the floor, they'll be doing some vitals and pain management and nausea medication. I mean, there's, the more education you give them, the better they feel, the more they expect, or what they'll expect. For people who have never had surgery before, they don't know how this process works. So if we don't explain it to them, they just realize that they get wheeled down to a room, then they move to another room, and then they actually move to another room, and they see all these people, and no one really explains anything to them, and they're too afraid to ask questions, and it's just, I just think the more information you give them, the more education you provide, the better they feel. So, medications that potentially affect surgical experience. We got corticosteroids because it actually affects the kidneys. We've got diuretics because, again, it would actually dehydrate you and affect the kidneys. Insulin, based on the fact that with stress and infection, your diabetes will actually, blood sugars will actually increase. That also causes your blood to thicken. And of course, that delays the healing time, and there's just a lot of problems. So the insulin is actually to keep your blood sugar within that 100 to 110 range. Antibiotics, they'll usually tend to do a prophylactic antibiotic during surgery to make sure that when they're opening you up, and as sterile as things are, there's still a potential of getting some sort of infection. And the prophylactic antibiotics to actually keep that from happening. Anticoagulants, so to make sure that you're not on something. Patients who have AFib or a history of blood clots, they're on either Coumadin or Eliquis or some sort of anticoagulant, and you have to be able to stop that several days prior to, because if you don't, you're going to bleed to death. Let's see here. We've got the thyroid hormone because of metabolism. Then we got the opioids and the over-the-counter and herbals, because people don't realize that over-the-counter supplements and herbals, I mean, they really can interact with other medications. So if we don't ask, they don't offer that up. Typical preoperative meds, they got sedatives and tranquilizers, anticholinergics. We've got narcotics, H2 blockers and PPIs, and prophylactic antibiotics. Again, the antibiotics to prevent infection. H2 blockers and the PPIs is really to make sure that your patient doesn't have either an allergic reaction, or it actually cuts down the amount of acid in their stomach. So if they do get nauseous, there's less of it to throw up. The narcotics is to fix the pain or prevent it, and then we got the sedatives and tranquilizers to really kind of put them under. Going back to your book, let's see where we are. I think page 423, surgical complications, I think that's kind of a good box to kind of know or at least understand that, like I said, it's not always about taking them from pre-op to surgery and everything's going to be wonderful and perfect. Some things just actually tend to happen. So that's good to know. There's also the valid informed consent. Um, On page 428, table 17-3 is all the medications that have potential side effects or things that or why, what happens when you actually give them. All right, so let's see here. Now we're actually in the OR. So we have a surgical team. We actually have the patient. We have a circulating nurse, which is the one that kind of, I don't want to say gopher. I mean, there's actually a valid job, but that nurse is the one who actually goes in between the rooms and getting what people need. There's tons and tons and tons and tons of equipment, and whether it be someone forgot to get something, whether they dropped on the floor, maybe it didn't work correctly, you need someone who's able to go in and out of surgical rooms to be able to get what they actually need. They're also the person who can actually kind of step in and help out too. So you also have the surgeon, which is the one who's actually performing the procedure. You have an RN first assist, which is the surgeon's right-hand man or woman. This is the person who, is able to hand stuff to the doctor or hold stuff or put your finger here, do all this stuff. And like I said, they're really the person who's able to truly help out. Then you also have the anesthesiologist, which is the person who's able to, monitor vitals and their breathing, making sure that they're getting enough medication to be under, but then not over-sedating them. I mean, it's a pretty big job. The surgical environment, everything is aseptic. They have a ventilation, which is air in. They have air filters, which is air out. So basically, the air that's coming into the actual surgical suite is purified, and then they also have some sort of return that allows it to be able to suck out all the air that's actually doing it. So it's almost like its own individual air conditioning unit where it actually puts in and pulls out. Temperature is usually 68 to 73 degrees, so it's very cold. And when I did my surgical rotation in nursing school, I froze my butt off because it was just cold, and you're sitting there and you're helping, but you're not really running around enough to keep warm. For surgical hazards, they have the lasers and they have blood and bodily fluids. I've seen some surgical suites where they're nice and clean after surgery, and then I've seen some that look like that someone was literally murdered in that room. So there's several hazards to that area. Basic guidelines for surgical asepsis: all material within sterile field must be sterile. Gowns are sterile in the front from the chest level to the sterile field, and sleeves from 2 inches above the elbow to the cuff. So basically from the waist up, and just your front is actually sterile. Only top of the draped table is considered sterile. Items dispensed by methods to preserve sterility. So basically, if you have a surgical table that's sterile, when you open up things, you actually open them and you drop them on the actual table. You don't actually open up the package, take the product out, and put it on the table. So items dispensed by methods to sterility, we talked about that. Movements the surgical team are from sterile to sterile, from unsterile to unsterile only. So basically, if you are the sterile person, you're moving from sterile field to sterile field, or sterile table to sterile table. If you're the circulating nurse or somebody who's actually not part of that, surgical team that's right there doing the procedure, you're kind of unsterile, and you don't, you just kind of go from unsterile to unsterile. So you kind of know your place and you kind of stick to it. Let's see here. Movement at least 1 foot distance from sterile field must be maintained. When sterile barrier is breached, area is considered contaminated. So basically, it's what's interesting is that once you know how aseptic or sterile technique works, and you're so used to it, you tend to be sterile all the time. So, but sometimes things happen and things become unsterile, and you really have to just start over, ditch everything that was there, and just get a whole new setup. Every sterile feed is constantly maintained, monitored, and items of doubtful sterility considered unsterile. Sterile fields prepared as close to time of use. From what I understand, there's only a certain amount of time that the sterile products and sterile tables, things that have been set up for a procedure, are only allowed to be opened and out for a certain amount of time, and I believe that's 4 hours. So with anesthesia, they have general, which is inhalation or intravenous. They have regional, which could be an epidural or spinal. And then we have moderate anesthesia, which is propofol. And we have local, which is actual lidocaine. And I believe that is actually in your book. See here, chapter 18, page 437, potential adverse effects of surgery anesthesia. That's actually a pretty good box to know. Let's see here. Inhalation anesthetic agents on page 444, table 18-1. Commonly used intravenous medications. Probably good to know, but I wouldn't necessarily spend all your time memorizing all those. Page 448. Here's your spinal blocks and local anesthesia. Things like that. So that would probably be really good to know as far as what the different types of anesthesia, as far as what they do and how they administer them and how they kind of affect your patient. Let's see here, comparison of anesthetic agents and delivery systems. So they have, let's see here, I think this is a PowerPoint from a book that was older, so I wouldn't necessarily go based on these tables and these figures. I would stick to chapter 18 in your 14th edition and do those boxes. And like I said, just kind of understand the difference between the inhalation, intravenous, epidural, spinal, and regional. So that's pretty easy. Here's your nerve blocks. I had a friend who actually had rotator cuff surgery, and the cervical plexus between the jaw and the clavicle, that's where they actually did his nerve block. It was very interesting to watch. They had this little ultrasound monitor where they were able to kind of determine where the nerve was, and basically an anesthesiologist comes in and he goes with a needle right to that point, and they basically blocked the nerve, and he had surgery, and it lasted for about a good 48 hours or so. They were actually pretty impressed by how well the anesthesiologist did by actually giving the block and actually hitting that right nerve at the right place, and like I said, just lasted a pretty long time. All right, so this is what I was talking to you about as far as the laparoscopic versus the open surgery. So if you have a patient who's having either laparoscopic appendectomy or laparoscopic gallbladder removal, basically they do the puncture sites. They have little probes that go in there the size of number 2 pencils. They'll go in, they'll actually chop it all up, and they'll actually suck it out through these holes. If it is too inflamed or if there's been complications, then they literally have to just make a midline incision and pull it out that way. OR complications, there's anesthesia awareness. I had my tonsils taken out when I was roughly 30 years old, and during the procedure, the medication had worn off or it wasn't strong enough. I actually woke up, and I woke up to them actually having the instruments down my throat, and I woke up to gagging and kind of looking around, wondering what the hell was going on, and that's when they gave me a little bit more medication and knocked me out. Other complications is nausea and vomiting. They can have anaphylaxis. Again, people are, they don't know what they're allergic to until they've received it. Respiratory complications could either be the fact that they stopped breathing based on the anesthesia, or maybe they were having some pulmonary issues. And sometimes, as much as I make this sound to be very easy and very planned and very systematically organized, patients come in through the trauma center, and next thing they're being whisked away off to surgery, and they don't have time to do all these things. So a lot of times complications happen. It's just you just need good teams to be able to realize what is a potential problem or becoming a problem and actually know how to fix it. You have hypothermia because of the fact that the suites are so cold, and you also have hyperthermia. A lot of times they'll actually use warmed normal saline or lactated ringers to keep you hydrated during the procedure, but also to keep you warmer. The hyperthermia could also be, they are doing certain procedures, and a lot of times they'll give like warm blankets and heating pads and all that stuff. And there's a lot of stuff that needs heat in order to do it, and you actually can spike the body temperature too high. The role of the ORRN is to reduce anxiety for your patient. The idea is for them to be able to explain, things to the patient and kind of put them at ease, and make them feel a little bit better. Reduce exposures, prevent injury, patient advocate, making sure that the patient understands what they're having done, making sure that they understand the risks, making sure that they, really truly want to have this done and that they weren't coerced and forced into it. I wouldn't say that every doctor does this, but I've actually had doctors walk into rooms and tell patients, if you don't have this done, you're really kind of either going to get worse, or you potentially die, or I just won't treat you anymore. And as much as, or as good as doctors are, they don't always have the best bedside manner. So I think for the OR nurse and the pre-op and the PACU nurses, and they're really there just to kind of make sure that everybody stays nice and calm, and everybody understands what's going on, and that the patients are aware of the potential risks, and making sure that this is something they want to do. Protecting the patient from injury, patient identification. A lot of times they'll ask in pre-op, OR, and PACU, and you may be asked by several nurses, the anesthesiologist, the doctor. Everybody and their brother will look at your armband and make sure that you are who you are, making sure consent forms and blood consent forms, and making sure that the procedure is the right place, the right limb, and everything else. So the identification is very important. Correct informed consent, verification of records of health history and exam. I've had friends who have had surgery, and literally every person who walked in that room not only checked the armband, but verified who the patient was, asked about allergies and what procedure they were having done. Then they would look at the paperwork, and then they would look at the labs. I mean, it just, everybody I think is just trained to keep looking at things over and over and over, and asking and looking and identifying, just because it's in their nature to make sure that, all it takes is just one person to be able to look and go, hey, this doesn't seem right. And then next thing you know, they're either fixing that potential problem, or they're catching, doing a good catch. So they'll also look at results of diagnostic tests. They'll look at allergies, monitoring and modifying physical environment, safety measures, verification, accessibility of blood. So again, they'll do the time and cross just to make sure that, potentially something could happen, and they have to be able to fix that. Types of wound closures. They've got the interrupted sutures, they've got continuous sutures, they've got staples, they've got tape, retention bridge, and other stay sutures. I think for the most part, I think I've seen more steri strips and interrupted sutures and staples than anything else. So here's surgical drains. The upper left-hand side is a JP drain. It looks like a grenade. Basically, you squeeze all the air out of it, you put the little top back on it, and then as it fills up, the actual JP drain turns into a bulb that looks like a grenade. The upper right-hand side is called a Penrose drain, and what that is it's actually it looks like a it looks like a straw that's very flexible, or it's actually made out of rubber. So basically the doctor will put that in, and it's basically allow things to drain out of the body, but it drains through this, and they'll put usually some sort of gauze or something to help absorb the drainage. And then the hemovac is the one that's on the bottom. Basically, it's the same concept as the JP drain. The hemovac actually collects blood. So basically, you push it down like an accordion, and as it fills up, it actually gets taller and bigger. And again, usually it's collecting blood. Post-anesthesia care unit, or PACU, the role of the RN is to assess the patient, make sure that they're breathing, make sure that they have a pulse and a blood pressure, make sure they aren't bleeding to death, control their pain and anxiety, and one thing, I've mentioned this before, you can take away the pain, but you can't take away sore. So, if a patient has, let's say, a laparoscopic appendectomy, you can control the pain that they have, but those puncture sites went through skin and muscle, and then you actually had removed part of the intestines, and you've shifted things around. Those are things that you kind of really can't take away pain, or you can't take away the soreness. It's really just going to be there. And I think once we explain patients that, if you're a 10 out of 10, I can bring you some pain meds to actually make that better based on the actual pain itself. But like I said, the soreness and the from the muscle and the skin and everything else, that's more like a 3 out of 10. And that's, as long as they realize that that's kind of tolerable, that's what you got to do. I do explain to patients that unless I, completely sedate them, they'll never be pain-free from that. And it just gets better the more days progress and the more they heal, the better they'll feel. Let's see here. You want to control the nausea and vomiting, whether it be Zofran or Phenergan or Compazine. I've had well, I can say most. I've had a lot of patients have reactions from anesthetic, myself included. Usually patients will have surgery, they'll recover, they'll come to the floor, and then usually the first sip of water or ice chips or juice, they tend to throw up. And then after that, they seem to be okay. But I find that if you give them Zofran or something that's an anti-nausea medication first, they tend to not do that, or at least they feel better. And call and give reports to and ship them off. So basically, when they're in PACU, they'll recover. They'll kind of keep them down there for about at least a good hour, making sure that they're stable, the blood pressures are good, and pulse ox and heart rate is fine, and then they'll actually ship them off to the floor. And once they get to the floor, the vital signs are going to be every 15 minutes times 4. So for they'll do vitals every 15 minutes for a whole hour, and then they'll actually do 30 minutes times 2, and then they'll actually do vitals every hour for 4 hours. And this is really to see the trend. If blood pressure is dropping and the heart rate is rising, then they're probably bleeding from somewhere. If their pulse ox is going from 92 to 96 and it's dropping down into the 80s or even the 70s, you'll see it. The idea is for you to start seeing trends, whether or not they're getting better or getting worse, and knowing how to act appropriately to actually fix those issues. IV fluids will usually be normal saline or lactated ringers, and this is really just to kind of rehydrate them because surgery tends to dehydrate them. Pain management will be either IV pain medication, or they can actually do a PCA pump, which is something that either the patient can push the button and they'll get some pain meds, or they'll actually have it continuous where there's a really, 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 really small dose that's just enough to keep them feeling a little better. Other interventions or assessments is level of consciousness in response to stimuli. So a patient cannot go back to the floor unless they respond and breathe on their own. When your patient goes from PACU to a med-surg floor, you're still taking care of 3 or 4 other patients. So you have to be able to watch that patient, do their vitals, make sure that everything is trending in the way it should. But in the same sense, too, you won't be in there for the entire time. So you have to rely on your aide to get the vitals. You have to rely on your self to be able to do the assessment. And, PACU needs to make sure that their patient is stable enough that they're able to go up without being continuously watched every minute that they're there. All right, so let's see here. Here it says look at page 445, 47. I think that's from an old book, so let's see what else do we have here. Well, that was chapter 18. Let's see here for chapter 19, which is post-operative nursing. Let's see here. 19-1, which is the chart on 457. That's the anesthesia provider to nurse report. I think it's probably good to know just based on, the nurse that's taking care of the patient on the floor is going to give a report to the pre-op nurse. And that pre-op nurse is going to give a report to the OR nurse, and the OR nurse is going to give a report to the PACU nurse, and then the PACU nurse is going to give a report back to the nurse that actually had the patient originally. So the more that more information is actually given, the more better communication, and everybody kind of seems to know what's going on. So let's see here. What else do we got? Well, 460 is the table 19-2. Good to know as far as postoperative nausea and vomiting medication. They also have 19-2, the chart for aromatherapy and postoperative nausea and vomiting. Because a lot of times, nursing interventions could be simple things like, doing some ice chips and eating clear liquids, after they do surgery, and you don't start people off eating a steak, and plus you don't necessarily feed anybody unless they start to have bowel sounds, right? So if your patient is hungry and they're thirsty and stuff, then you can kind of do things in moderation and just give them a little bit of something. And like I said, as the bowel sounds start to wake up, you actually start to feed them. So let's see here on 19-3, the chart on 463, at completion of education, the patient and or caregiver will be able to. So this is actually pretty good for discharge after surgery, because not every patient actually will go to the med-surg floor. A lot of times they'll actually go home, especially for those who have scheduled the surgery and planned it very early in the morning. And they're finding that the patients can, as long as they're stable, can actually go from having surgery to going home. If there's not much that I'm doing that they can't do at home, and they're stable, and the procedure was easy enough that there was very, very low risk, then why not send them home? I mean, they're able to sleep in their own bed, and they're able to take their own pain meds. They're able to feel better on their own, and I think recovering at home is actually a lot better than being stuck in a hospital. Let's see here, 464, intermediate postoperative nursing interventions. That's probably a need to know. Let's see here, there's a lot of nursing diagnoses within these pages. Let's see here, we talked about relieving the pain. Encourage activity. I think the faster these people get up and the faster they move, the better they're going to recover. Not only does it allow their bowel sounds to start to wake up, and also the more they move, the more they're able to blow a lot of that anesthetic off. The more they move, the more able to actually expand their lungs and actually be able to open things back up again. I think the incentive spirometer is probably a really big thing, as far as not only does it open up their lungs, it allows them to actually blow the anesthetic off. It also keeps them from getting pneumonia. It's easy to do. You do every hour times 10. Or patients who forget, tell them to do it during the commercials, because commercial comes on, you do the incentive spirometer. Like I say, you're able to blow a lot of that stuff off. Let's see here on page 473, the selected postoperative complications, probably a nice thing to know. Potential causes of postoperative delirium. We mentioned that before. And that's pretty much about it. So, read the chapters, go through this PowerPoint. I think this is, good information and definitely necessary, because based on med-surg floors, we get a lot of postoperative patients. And I think, like I said, a lot of it is really just more assessments and interventions, as far as, reacting to things. And that's pretty much it. So let me know if you have any questions.